Good afternoon. My name is Brandon Broussard. We are the respiratory therapy class of the University of Texas Brownsville, class of 2013. Today we'll be doing a brief scenario of inserting the UVC line and also inserting epinephrine and volume expander into the UVC and also to the ETT tube. But first we'll be covering some of our equipment and medications. After that we'll go into the scenario, but keep in mind that I will only be going over the first resuscitative care procedure since it is a long procedure from beginning to end. We will come into place when chest compressions start. But before we do that, let's take a closer look at our equipment and medication. So before we start, we're going to need some special equipment. We're first going to need sterile gloves, a scalpel or scissors, antiseptic prep solution, umbilical tape, your umbilical catheter, and your three-way stopcock. You will also need your syringes with medications pre-labeled preferably. Our first medication will be 0.3 epi that will be given via the ETT tube. Notice the yellow signifying its epinephrine. Second will be 0.9 epi given via UVC. We also will need our flush. And finally, we'll have our 30 milliliter normal saline given as a volume expander. Let me give you a brief indication of our epinephrine. Epinephrine is indicated when the heart rate remains below 60 beats per minute after you have given 30 seconds of effective assisted ventilation, preferably after endotracheal intubation, and at least another 45 to 60 seconds of coordinated chest compressions and effective ventilation. Our recommended route is intravenously, and in this case we will consider endotracheal route while our intravenous access is being obtained. Administration of epinephrine can help reestablish normal myocardial cerebral blood flow. Now we will begin with our scenario.
Let's do this. Get our team ready. Get the muster set up.
Please be patient while we get everything in place. As I said prior, I will briefly be covering the first initial steps of resuscitation. So this means that the patient has already been intubated and PPV has already been initiated. We already obtained relevant perinatal history in our equipment check. We received the baby, at which the baby was term, limp, apneic, and pale. We've gotten our first respiratory rate, which was apneic, once we received the baby, and the heart rate was 30 beats per minute, far below 60. We've initiated positive pressure ventilation at 40 to 60 breaths per minute, and we've gotten our additional help. Our status has continued to stay the same. Baby has continued to be apneic. Heart rate is still at 40 with no breath sounds or chest movement. We will have continued administering PPV, and our heart rate still is at 40 beats per minute, far below 60 with no saturation. This is where our team will come into place. The doctor will now request chest compressions, oxygen at 100%, and the need for intubation as he prepares.
Okay. Kim, please go ahead and start chest compressions. And Stacy, you're doing well. If you guys get tired, you guys can go ahead and switch up. Increase to 502.
Chest compressions and ventilations will continue for at least 45 to 60 seconds. Our heart rate will still be at 40 beats per minute. SpO2 is still at 63%. It is now when the doctor will request epinephrine via ETT tube.
Okay, we're going to go ahead and at least give 0.3, baby weighs 3 kilograms, we're going to need 0.3 milliliters of epinephrine via ETT tube. You want to go ahead and grab it because I already have my sterile. Stop chest compressions.
Administering 0.3 of epinephrine.
Administer it now.
Chest compressions is immediately given back onto the patient. It has been confirmed that the epinephrine has been given, and now the doctor will begin preparing the UVC. As you see, we are giving chest compressions, and the chest compressions, remember, has to go 1/3 of the anterior posterior depth. It can be given with 2 thumbs or with 2 fingers, as you see now. The doctor is preparing his area to work with. He will follow up by prepping the base of the lower 2 centimeters with prep solution. But as you can see now, he's tying the umbilical cord off, unclamping it. He is now cutting the umbilical cord 2 centimeters above the abdomen. His cord has been with antiseptic solution, and now he is inserting it 2 centimeters into the vein, 2 to 4 centimeters. Once inserted, he will open the stopcock between the baby and gently aspirate, detecting blood return.
We do have appropriate blood flow.
Now the heart rate is at 40 beats per minute. SpO2 is at 63% with positive breath sounds and positive chest movements. The doctor will now request the epinephrine via UVC and confirm the order with another.
Okay, we're going to have to give at least 0.9 milliliters of epinephrine. You want to confirm that?
What, 0.3 epinephrine?
He is now administering the epinephrine via the UVC. He announces that the epinephrine is in,
Epinephrine has been administered. Via
while someone else is documenting the dose, route time, and response time. We will continue PPV and chest compressions for at least 45 to 60 seconds after giving the epinephrine. We will re-evaluate the heart rate in the pulse oximetry. Heart rate is now at 70 beats per minute, SpO2 is at 67%, and the baby has finally had his first gasp. Perfusion is still poor and pale. Now that the heart rate is above 60, the doctor will order discontinuing of chest
Go ahead
compressions.
and stop doing chest compressions. The baby's heart rate is becoming adequate now.
He will next request a volume expander, reiterating the estimated weight of the baby.
Okay, I'm going to need 30 milliliters of normal saline so I can expand his volume. I'm going to go ahead and administer it now.
He's now administering the normal saline, which will be given over 5 to 10 minutes. Notice how the normal saline is also labeled. After it is in, he will announce that the medication is in and being given. Now, we will have a continued 30 seconds of PPV with ETT tube still in place. Notice how the care provider is pressing the ETT tube against the hard palate, keeping it secure.
Volume expander has been delivered.
We will now reevaluate. After 30 seconds, respirations have become occasional gasps and heart rate has improved to 120 beats per minute. We will now titrate the oxygen down to the new saturation of 74%, matching it. We will decrease the O2 to 70%.
Go ahead and decrease the oxygen to 70%.
Decreasing oxygen to 70%.
Titrate it. Okay.
The child is still having occasional gasps. Heart rate is continuing to climb to 140 beats per minute. SpO2 is 97%. At this point, we may continue PPV for 30 additional seconds to help ensure stability prior to transport to nursery. We will continue adjusting the oxygen based on the oximetry and the newborn's age. Now the doctor and the team will make a team decision to update the family, secure the ETT tube, secure or remove the UVC, or move to post-resuscitation care.
Okay, we're going to leave this UVC line in place for further medication administration. We're going to try to wean as much oxygen as possible. I'm going to go ahead and notify the family that the baby's going to be okay. Okay?
Okay, so you're in the ETT tube, doctor.
Thank you for joining us.